technical problems on both ends. But we, when technology works well, it's the best, and when it doesn't, it's our greatest challenge. So a big thank you and welcome to Sharon Alroy-Preis. We're so delighted and honored that you're here with us today. She is Israel's top public health official. As we like to say around here, she is the Dr. Fauci of Israel. But maybe we should say that Dr. Fauci is the Sharon Alroy-Preis of the United States. Maybe that's more appropriate. A special thank you. Joining us, although he's not here yet, will be Dr. Michael Mendoza, who's just done an extraordinary job as the lead in the Monroe County Health Department. He will be here as well. We got confirmation on that. We'll give him a chance when he's on to say a few words. Also, a special thank you. We have leadership in the medical community, both from those who've done research on the vaccine and those who've done rollout of the vaccine. It's been quite an incredible journey. I've been participating on the Finger Lakes Task Force with vaccine rollout, representing the Jewish community. It's been really an honor to be a part of that task force, and it's been an incredibly interesting learning experience. And I really think our county has just done a remarkable job. And just a quick note about Maimonides. Maimonides is our medical professionals division of Federation. We've been quiet for the last year. I think our medical professionals have had other things going on, but we're looking forward to creating some programming next year. Hopefully it will be a little bit more of a sane year. And we so appreciate our medical community here in Rochester, all the work that you have done and that you continue to do on our behalf. We obviously live safer, healthier, happier lives because of all of you. And this partnership that we have burgeoning between our Maimonides division and with the city of Modi'in is really quite wonderful. There's certainly a lot to be learned from each other, and our partnership continues to deepen and grow in so many ways. And we are delighted by that and so happy that you are here. And with that, I'm going to hand things over to Dr. Larry Chesson, who's been intimately involved in the development of our Maimonides program and will help facilitate the conversation this morning. So Dr. Chesson, as always, thank you so much for your leadership and dedication.
Good afternoon, everybody. And I'll start a program by first congratulating the Israelis in their excellent response to the COVID problem with their immunization program, and start by questioning Dr. Alroy-Preis. Tell us, which vaccine are you using in Israel? There's now the Moderna, the Johnson & Johnson, the Pfizer. Is there a universal program that you're using?
We have been using Pfizer vaccines all along. That's basically the only vaccine we have used so far. It started with by the fact that this was the first vaccine that was available. And once we started with it, and our, as you'll see by the lecture, our purpose was to vaccinate as fast as we can, as many people as we can. And so we started with the first available. And after that, when Moderna became available for us, we didn't have a big shipment of Moderna anyway. So it became available for us in March. We didn't want to mix the vaccines because we were worried about safety issues when people are so used to doing, to providing the Pfizer vaccines, diluting them in a special way, giving 6 doses. Now we're moving to 10 doses. You don't need to dilute. We didn't want to mess with that. So we said we will just continue to vaccinate with Pfizer vaccines, and for specific population, if that will be possible, when different providers are giving the vaccines, we can give Moderna there. So we were trying to do this for prisons, for example, when you have really different healthcare providers providing the vaccine. It was not available for us. Moderna was not available for us when we wanted to vaccinate prisoners. So at the end, the majority, if not all, is vaccinated by Pfizer with 2 vaccines.
Regarding the vaccination program, could you give us an idea how many people in Israel have received a vaccine, and what has been the efficacy with the vaccination program?
You'll see it in the lecture, but I'll give you a promo. So the effectiveness of the vaccine is very high. We were actually the first nation to publish the data on a nationwide scale. And so what we've seen from the beginning was 96, 97% effectiveness of the vaccine for different type of outcomes. The only thing we're not sure about is how much it can reduce asymptomatic infection, because our policy of testing has changed. So people who are vaccinated don't need to be tested as often as people who are not vaccinated. So we're not quite sure about asymptomatic testing results, but for all the rest, symptomatic, hospitalization, critical, and severe hospitalization and death, we are sure about the results, and it's highly effective, the vaccine. What we have come to is approximately 85% of the eligible population being vaccinated, or you'll see it in the slides, but most of the people who are over the age of 60 are vaccinated. And all in all, it's about 85% of the eligible 16 and above population. What we do have is a very young country, a very young nation. So we have now, when we look at all the population in Israel, we have about 65% of the population who is either vaccinated or have been recovered. So they're protected in some way from corona. And about a third are not. And this is because we have very big population of kids.
Have you, what is the age group that you're going down to? I think you said 7 to 16. Are you doing anything with younger children?
So at the moment, we've started this week. We started with vaccinating 12 to 15. Again, first, I think in the world, we saw a connection in the younger age group, 16 to 30, with boys or men, young men, some correlation with myocarditis, which is, for those who don't know, inflammation of the heart muscle. And so based on that information, it's still pretty rare, but it's a side effect that we've gone to very length in order to see if there isn't a connection. We had 3 different teams working to see if there is any kind of a causal relationship to this side effect that we saw. And we have come to the conclusion that there is some connection. And so weighing this information with the really low disease rate at the moment in Israel, we have decided to recommend this for kids 12 to 15 who have themselves chronic conditions, even morbid obesity, but obviously diabetes and other chronic conditions, asthma, kids that are not healthy, kids that they're people who they come in close contact to are considered high-risk population, either their parents or their grandparents, but people who come in close relationship with. And for those who are planning to travel, because we know that in the world, COVID-19 is still a pandemic, a roaring pandemic. So we have opened it to everyone, but said that these 3 populations are the one that we are really recommending to be vaccinated at the moment.
Have you seen any inflammatory response to your vaccination program, thing that we see in children in the United States? And has that changed your attitude towards the vaccine program?
No, so we've seen it. We've seen it along the way. We've seen it with adults. There was a lot of bad media, a lot of groups resisting. We're near the airport. I'm sorry. Sometimes there will be a plane flying. There was a really very vocal group of people who are anti-vaccinations. And they started at the beginning when we started the vaccination campaign in December, and they were very vocal. And they threatened many people in the medical community, especially people from the Ministry of Health, but not just them. We have an advisory group of infectious disease physicians and epidemiologists, and they threaten really very vocal people in that group that were obviously recommending vaccines. So we have been dealing with this all along. Obviously, with kids, it became intensified. So, and it's both the anti-vaccine folks in the country, but also now with the low disease rate, people are saying, well, why are you forcing vaccines when the disease is not here anymore? And so thinking about especially the fact that really we don't have a lot of cases of corona at the moment. We have about 10 to 20 cases a day, and some of them are imported, are people who are coming from abroad. So we really felt that at this point we don't need to recommend to all the 12 to 15, but we have been dealing with this for months, and it's not easy, I have to say.
Changing the direction, have you seen any variants appear? We know that there's an outbreak in Brazil, South Africa, and India. Have you closed borders to these people? And are you seeing any of these variants coming into your country? And have they caused any problem?
Yes. So at some point along the way, it was September, when we realized that the virus is about to change. We know this from virology. It's not something that will surprise us. And we started to contemplate on this genomic sequencing network of labs that will be able to do genomic sequencing for epidemiological reasons. And then we did this kind of in a slow motion. We dealt with other things. And so in December, when the UK variant came in, by the time that we realized it's there, it infected so many people that actually what one of the drivers for a really high surge in disease in Israel that led to the third lockdown. And it was a very prolonged lockdown. It had a combination of people by the third lockdown are less compliant with the restrictions, but also the UK variant that was we saw a huge shift in the outbreaks. Instead of a person maybe infecting 1 or 2, 3 other people, they were infecting 10. And instead of this taking like 4 to 5 days, it was within a day, all the kindergarten kids were infected by this one teacher. So it became very rapidly spreading, and many people were infected once there was one confirmed case. So we definitely saw and felt the variant influence in Israel. Obviously, at that point, we sped up all the plans to do genomic sequencing. At the moment, we are sequencing all positive test results from the beginning, even before now. Now we have really few cases, but even before that, we decided that as a policy, we're going to sequence all the people coming from abroad, because we understand that even though variants may as well create in Israel, most of them will probably come from the outside. So focus on abroad travel, focus on people who have been vaccinated and sick, people who have been recovered and sick, and people who are young, less than 40 years of age, and are in critical conditions in the hospital. So something that feels like there could be a more severe variant that cause severe disease. And in addition, do like 5% of the community confirmed cases just to see if there is not a variant that pops up in Israel as a new thing. And so we really enlarged our genomic sequencing capability, and now we track all of them. So we have the Indian variant, we're not supposed, by the way, to call them by their names anymore. It should be alpha and beta, but I'm not sure if everyone knows the nomenclature by now. But the Indian variant that we're concerned about, we see what's happening in the UK. And we had a few cases of the Brazilian variant. What we are doing that I'm not sure all countries are doing is that we're being very active with the variants. So it's not just that we do genomic sequencing and for epidemiological purposes to see what percentage of variants are in Israel over time. We're actually very active once we find a variant. So once we find a variant of concern, we're doing a second round of investigation. We're contacting all the contacts of that person again. We are sending home sampling. So we sample them at home. We make sure that we pass those names to the police to make sure that they're staying in isolation. So there's a lot of activities around variant confirmed cases to make sure that we don't let this spread in the community. And it's a lot of work, but it has been worthwhile.
Two other directions to go in. In this country, we use remdesivir selectively and monoclonal antibodies. Have you done any seroepidemiologic studies or assessment of your variants to either remdesivir or potential use of monoclonal antibodies in protection? These are
no, so we haven't
issues.
done. Yeah, we haven't done that yet. What we have done is trying to see whether people who have been recovered from the wild type or people who have been vaccinated, what their antibodies, how protecting are those antibodies against different variants. And we published some of the data, and some of the data is going to be published, but not trying to to see different treatment options on those variants. Yeah.
On the call is Dr. Michael Mendoza, our Monroe County Health Commissioner. Michael, would you weigh in on some of the issues regarding, have we seen any variants appear in our county, or what is the approach that the county is taking towards monitoring?
Dr. Chazin, it's Debbie. I don't see Dr. Mendoza on the line at this exact moment.
Okay, well then I'll cancel that question.
We can come back
and
to
move
him.
on.
Okay.
Regarding the immune response in the nation, have you been monitoring that? And can you give us an idea of what efficacy you have in terms of protection that's antibody mediated?
Two different variants.
Well, to the primary agent as well as to variants.
So we have done those testing. What we saw is that for the UK variant, people who have been vaccinated and recovered individuals, their antibodies are protecting against the UK variant very well. For the South African, we saw a drop in the amount of neutralizing antibodies compared to the wild type and to the UK. In the middle, we saw for P1, for the Brazilian variant, we saw a reaction that was sort of in the middle between the South African and the UK. We are now testing the Indian variant, to see how well antibodies from vaccinated individuals and recovered individuals are protecting against that variant. So it's a lot of work to grow those variants in the lab, in cultures, and then it takes several weeks actually to do this work. We are close to finishing with the Indian variant as well. So I have to say we have been also very proactive. So we actually got samples of the Brazilian variant even before it was in the country. We approached Brazil and we asked for a sample to try to grow it in the country. So we know we were very afraid of the Brazilian variant seeing that there is increase in disease rate in a country that was supposed to be in a herd immunity from recovered individuals. And so that looked from afar very, very scary. So we actually approached the Brazilian government to try to get a sample, and we did. So we actually grew the virus in the lab even before we had a case.
Well, I've been told by our super moderators that we can close this session so we can move on. Want to thank you for taking all my pointed questions. And we'll await your lecture, which will begin shortly. Thanks for everybody.
I have to say that I'm still having problems with the lecture. This is the problem, that I couldn't go on the Zoom with ability to open the lecture, but I'm trying to deal with that. So
All right, well,
hopefully that will work. Maybe I'll need to be in 2 Zooms for that, but we'll see.
thank you again, and thank all the people that joined us in this session. Shalom.
Thanks, Dr. Chesson.
Hello.
Dr. Alroy-Preis, if it's a problem, I wonder if you could email one of our staff the presentation. Maybe we could share it and somebody could sort of work with you on it.
Yeah, so I think I'm able now to at
Okay.
least open it in one computer and then take it from there. But
I just want to quickly welcome, because Dr. Michael Mendoza is just coming into the call. So our Commissioner of Monroe County Health, Dr. Michael Mendoza, welcome to our event, and just want to recognize and thank you for taking the time to be part of this.
Dr. Chesson, maybe want to open with the question that you asked Dr. Mendoza, give him an opportunity to say a few words.
I'm
we
sorry,
get started.
I missed what you just said. I apologize.
No, that's okay.
Hi, Michael, Larry Chesson. The question I asked, have we seen any variants in Monroe County that have been of issue and that you've had to deal with?
So the B117 variant.
sorry, that's me.
I'm getting feedback. Is that me or you all? Someone else. About 60% of the local strains are the B117 variant, which is what was initially isolated in the UK. The B1127 variant is the South African variant, I believe, the one that was in South Africa. And that we haven't, I'm not aware of any prevalence statistics on that, but my understanding and my observation is that it has not really posed a concern. None of these variants really have really demonstrated much of a concern at all, because since our numbers are going down so quickly. But what remains to be seen is how these variants behave when it's colder. So that's the one thing that we're not sure about yet.
And the interesting phenomenon is that influenza virus has not appeared in this community at all. It really, the coronavirus has suppressed activity. You want to comment about that?
I don't know that the coronavirus has suppressed the activity. I think it's our behavior that has suppressed the activity. There have been influenza cases, to my knowledge, here in Monroe County, but they just haven't spread very far because, it turns out when you wash your hands and wear a mask, influenza doesn't really stand much of a chance. So I think the question going forward will be, to what extent will society tolerate wearing masks as a flu prevention method?
Right.
Every year for as long as time, we've accepted 68,000 fatalities in this country as acceptable as a result of influenza. And I would argue that we ought to reconsider that, because 68,000 people is 68,000 people. And if frankly, all it takes is wearing a mask, if there's anything good that came out of this pandemic, it's that, wearing a mask is acceptable and normalized. I mean, in much of the way it is in many countries. Many parts of our community are still coming around, but I think when push comes to shove, frankly, I will very likely be wearing a mask to prevent influenza spread in the winter when flu is prevalent.
Thank you.
Great. Thank you so much, Dr. Mendoza, and thank you for being here, for sharing your insights. I think we're going to kick it over to Kim Holtzman. We are going to start the community portion of this event where Dr. Alroy-Preis will give us her presentation. But before that, I really want to allow one of the members of our Partnership Together steering committee and also member of the Adult Education Committee, Kim Holtzman, to say some welcoming remarks.
Thank you, Michal. Thank you all for joining us today as we learn about Israel's very successful COVID-19 response. We are so very honored to have Dr. Sharon Alroy-Preis sharing her knowledge with all of us. The event is a collaboration between two Greater Rochester Jewish Federation programs, the Partnership Together Rochester and Modi'in Adult Education Series and the Maimonides Society. Many thanks to Hila Hadass, without whom we would not have had this incredible opportunity to hear Dr. Alroy-Preis. A few other notes about today's program. This event is being recorded. I ask you all to please stay muted throughout the program. Finally, we will have a Q&A session at the end of Dr. Alroy-Preis's presentation, moderated by Dr. Martin Zand. Dr. Zand is a professor of medicine and public health science and specializes in nephrology as well as immunology, and is a member of the Partnership Together Steering Committee. Thank you, Dr. Zand. Please type your questions into the chat and Dr. Zand will pose them to our speaker after her presentation. Dr. Sharon Alroy-Preis is a physician specializing in internal medicine, infectious diseases, and public health, and currently serves as the head of public health services for Israel's Ministry of Health. From March 2018 through July 2020, Dr. Alroy-Preis served as Deputy CEO at Carmel Medical Center, and prior to that as Quality and Patient Safety Division Director at Carmel Medical Center. Before that, Dr. Alroy-Preis worked as Senior Physician in the Internal Medicine Division and Unit for Infectious Diseases and their Prevention at Carmel Medical Center. From 2010 to 2013, Dr. Alroy-Preis was the New Hampshire State Epidemiologist. In this role, she was responsible for supervising and inspecting infectious diseases in the state of New Hampshire. She was also responsible for investigating outbreaks of infectious diseases and served as a liaison between the Department of Health and the Center for Disease Control. Dr. Alroy-Preis holds a Master of Public Health from Dartmouth College and a Doctor of Medicine from the Technion, Israel Institute of Technology. In addition, she earned her MBA from Tel Aviv University. And here is Dr. Alroy-Preis.
Thank you so much for this lengthy presentation. I hope you can see the slides well. So what I've been asked to talk about is the national COVID-19 immunization campaign in Israel. I thought of sharing both our strategy and the challenges that we faced and our solutions for them, and then at the end, our results. So first of all, for those of you who don't know, I'm sure everyone does on this call, but for those who don't, Israel is roughly 9 million people, and 30% of them are under the age of 16, so not part of the eligible population at the time we started this vaccination campaign. And we have a very strong public health system that comprised of 4 HMOs that covers all individuals nationally. And we have hospitals that are all regulated by the Ministry of Health. Part of them are part of HMOs, especially Clalit. Many of them are part of our governmental, and some of them are privately owned. So our principles were to base the campaign on existing community health system. We had a lot of discussions at the beginning when we thought maybe it would be really good to bring in all the people who want to be vaccinated into this centers that the Army will put up or some other forms And we decided very quickly with the CEOs of the HMOs who said, let us do the work. We are vaccinating people on a day-to-day basis. We know our population. True, we never tried to vaccinate 50,000 or up to 200,000 vaccines a day. That will be a challenge, but we can do it. And so we went with them and we started with vaccinated in the hospitals, the healthcare worker staff, but the population was supposed to be vaccinated in HMOs. Another principle was to vaccinate as rapidly as possible to reduce morbidity and mortality. So first of all is the rapidity of that, to say once vaccines are here and we know they're safe and they went through the quality and batch tasting and everything that we do, now we're going to launch this campaign to try to vaccinate as many people as possible, doing this by prioritization. I'll get this in a minute. But we're trying to reduce morbidity and mortality. We're not trying to reduce transfer of the virus, because if you're trying to do that, then you need to vaccinate the 16 to let's say 40 population. You need to do it for the people who are spreading the virus. We said no, the focus should be to reduce morbidity and mortality. And we started with the older population, 60 and above, and then reduce the criteria of the prioritization gradually. There was a strategic decision that we're not going to compromise on safety. We're not going to do shortcuts. We're going to wait for the batch testing as we do for other vaccines. We're going to wait for the FDA approval. We are going to make sure that we give it by the protocol. There are different countries who chose, because different situations in those countries, to give only one dose of the vaccine. And we said, we don't know if that's effective or not. We're going to give the protocol that was approved by the FDA. And sure, we don't know what the supply will be, but let us work on the supply part and make sure that we get all the vaccines that we want and not compromise on the protocol that was actually approved by the FDA. One of the criteria was prioritizing by simple criteria. At the beginning, we thought, well, maybe we should give it to people with chronic diseases who are more at risk. And very quickly, we realized that if we give a list of criteria for people, it will be very hard to manage. If we go by simple rules, now you vaccinate 60 and above, even if the person who is 61 and has no chronic conditions, they meet the criteria. We don't go into very complex algorithm of chronic disease that qualifies. We go by age because that will be very easy to manage. So obviously 60 and above, medical staff, first responders, we took them as first. And then we gradually reduced as we had more and more information about the supplies that we had. We reduced the age threshold to get the vaccine. And within 2 months, even less, we got to a point that everyone in Israel who is eligible for the vaccine, 16 and above, can be vaccinated. We had to, sorry. Maybe I'll close the window. That will do something, probably. This is the tourism coming back to life in Israel. So we had to fight fake news all along. I was asked previously whether we had a problem with fake news and anti-vaccine campaigns with the kids' vaccine being available. We had to deal with fake news from the beginning, even before we had vaccine in Israel. Even before December, when there were thoughts about vaccines being available, we started dealing with fake news. And we knew that that's one of the challenges that we'll have being this a vaccine that it's new, people would feel hesitant, maybe Pfizer or Moderna cut corners in safety. We had to really work on this arena to make sure that we give the data accurately and fight the fake news all along. What we have is a national electronic medical record. Each HMO has its own, but there are some systems that share data on a routine basis, and we decided to use that data and also to track the progress of the vaccines, and to ask people to report adverse event there. And so that was crucial. I have to say that it was also very crucial that all the COVID-19 test results are coming online to the Ministry of Health. It's something that along the way, pretty early, we realized that you can't manage this outbreak without knowing exactly how many confirmed cases you have. At the beginning, we had a huge challenge in increasing the number of the tests that were available in Israel, the PCR testing. And then with that challenge of actually having PCR available, we had the challenge of connecting, IT connecting all the labs in Israel to the Ministry of Health for reporting. But the fact that everything is reported online, both the COVID-19 test results and the status of the vaccinations, you knew every day how many people were vaccinated and where, and so that made it very easy. And the last principle, was to be transparent. That's part of dealing with the fake news, but it's more than that. It's a statement saying, this is a vaccine that we're going to track over time. We're going to be very transparent with the information that we have about its effectiveness, about adverse events, about everything that is happening. We're not trying to hide anything. We had a contract with Pfizer. Part of the contract was in order to get the supply as quickly as possible to Israel and allow us to give vaccines to every citizen. And so that contract, except for minor places that had confidential information of Pfizer, but the contract with all the information there is transparent to the public. And so that was part of a huge principle for us. Not moving. Wait, I'll stop sharing. Maybe I'll do it like this and this will probably move better or not. Okay. Yes. Can you see it like this? Or does it need to be large? Okay, so the strength of the Israeli health system, as I said, it's strong, it's centralized. It has national health insurance with coverage for all residents, and that the question of who is going to pay for the COVID-19 test or who is going to pay for the vaccine was never a question. It was clear that it was under the health insurance. As you see, and I said before, we had 4 competing but cooperative national HMOs. Everyone is tracked with a personal ID from birth, so it's very easy to identify people. All the healthcare workers are documenting in EMR, and MOH, the Ministry of Health, is linked in real time to all those results. But also, and we have to bear it in mind, Israel has extensive experience in emergency preparedness and response, and it has a national psych geared toward mobilizing in crisis. So this is a nation known for emergencies, as we recently saw. And so the ability to say we need to work here fast is something that is not strange to us. The challenges: this was the first time ever emergency national vaccination campaign of this scale. We did have other vaccination campaign, measles along the way, polio, but it was not of this magnitude at all. There was unknown willingness of the general population to get immunized. This was a new vaccine. People were hesitant. And so we needed to really bring out the data of why it's safe and recruit people who are opinion leaders and make sure that they speak, not just us in the Ministry of Health. Another big challenge was at the time we rolled out this vaccination campaign, our healthcare system was actually stretched. We were in the middle of the third wave of COVID-19 cases, and there were a lot of people, very sick people in the country, both in the community taking care by the same HMOs that we're now asking them to vaccinate, and also in the hospitals that part of them took part in this vaccination campaign. So on one hand, they were dealing with COVID-19 pandemic, and on the other hand, the same people were vaccinating, and that was not an easy task. The challenges by the vaccine itself, the logistic challenges, as you all know, ultra cold storage, short lifetime, limited information about the stability. One of the challenges that we saw along the way very early on is the tray that has roughly 1,000 doses. And if we want to get to nursing homes, we want to get to remote locations, you can't get 1,000 doses without huge dispensing some of them. So we needed to figure out how to make the trays smaller. And the usual things with the vaccines that we need to test the quality and batch release and testing, and the fact that we didn't know their supply schedule. So that was a big challenge. So our solutions for the logistic challenges were, first of all, to centralize the control and planning control center in the Ministry of Health. So there was one location where all the vaccines were dealt. They were giving to the different HMOs, but everything was organized centrally. I'll skip some of the information, but the fact that the immunization was done by the HMOs was a solution. They knew what they were doing. They knew how to call on to their patients. They had follow-ups on them. So that was important. We decided from the beginning, because we are trying to stick with the protocol of 2 doses and we're not sure about the supply, that we're going to secure a second dose for every first dose distributed. So every person who got the first dose, we saved a second dose in a different location to make sure that we're not running out of those doses. The distribution, we had a weekly plan of shipments to avoid wastage of vaccines, and splitting trays to smaller tray size, as you'll see in a minute. For the professional challenges, we had multidisciplinary daily situations meetings. We had outbreak management team when we looked at the data. We had advisory committee on immunization that even before the immunization actually got to Israel, tracked all the information in the literature about the different vaccine, not just the Pfizer vaccine, and then helped us with the prioritization. They were all professional people, infectious disease folks, epidemiologists that helped us, vaccine professionals who helped us create the criteria and then enlarge them. We had written guidelines, we had immunization training, we had thousands of people joining immunization training webinars to our healthcare professionals to teach them about the vaccine that is new, how to work with it technically. We had created 3 different committees that are specific on immunization. One of them, the adverse event committee, that tracked all the information about the adverse events that were happening close to immunization, and effectiveness committee that followed the number of cases of COVID-19 cases along the way when we know for each individual if they're vaccinated or not. And another committee that is not mentioned here, but was also very important, was the committee of how to make all this information clear to the public. So all our messages went to this committee that was trying to make sure that our messages are clear and sound and can be explained. We realized that we need we realized that we need to incentivize people because the older age groups ran to be vaccinated, right? So they knew that 60 and above, they are really at risk from the disease itself. And once it became available and they were first in line, they came very quickly to be vaccinated. I'll get to a moment about the bedridden and the other that we need to get to them, but everyone who couldn't get to us got to us very quickly. But people, when we drop the age groups, people who are younger and not quite sure what they're getting from this vaccine needed to know that there's a value for that vaccine aside from being healthy, because they felt healthy and they didn't feel endangered by the disease itself. So we gave everyone a certificate of immunization. Every person who got, and that was a risk. The second thing that I'm about to say was a risk that we took. We said that everyone who is vaccinated will not need isolation when they come into contact with a confirmed case. And that's a big incentive. So it has rationality behind it. You're saying if the vaccine is effective and you trust this vaccine, then probably they are not going to be sick. They're not going to suffer much from the disease. The risk is that at this point, we didn't know exactly how much they can be still infecting others. But they were still with masks. They were still with a lot of social restrictions anyway that were kept. And so we went with that. And the last thing is the Green Pass. We created in Israel a Green Pass. That was actually not for the purpose of incentivizing people to be vaccinated. The purpose of that was in order to create safe opening of economy. So we came out of a lockdown. We wanted to start opening economy, and opening economy after a third lockdown, people were really anxious to start opening everything at the same time, stores and culture events and sports events and everything at the same time. And we knew that if we open everything at the same time, then the disease will increase again. We still had thousands of people, confirmed cases a day. And so what we said is, if this is the Green Pass, is you can enter a place that is not, you don't have to go there. It's kind of it's a voluntary thing. So the Green Pass was not operated on stores where everyone need to go and do grocery shopping or buy clothes. So we took the stores out of this, but social events or sports events, you don't have to go there. So we can say you can enter those places if you have a Green Pass, which means that you either vaccinated or recovered individuals or have negative test results for corona. So we're trying to create this zone, this place, this setting where we think that there is low risk of the disease. It's not zero, because vaccinated people can be sick. Recovered individual can be reinfected. Obviously, negative test results could be falsely negative, but it's still lower risk. And in that setting, we think it is safe to increase the numbers. So we said at the beginning, 300 people under Green Pass can go into a sport event or a culture event. No one would have thought of allowing 300 people to gather together in one space, closed space, at that time. So the Green Pass actually allowed us to open economy quicker with larger amount, but still make it safe. But it's here on the slide because also it's incentivizing people to be vaccinated. So if younger people wanted to go to the gym had to operate at that point in time with a Green Pass. You couldn't enter a gym without a Green Pass. So that's an incentive for people to be vaccinated. Again, that was not the reason. The reason is the gym, for our purposes, from epidemiological reasons, where you are in a closed space without a mask, breathing heavily, this is a dangerous place. And the gyms were closed in Israel for months. We said, we can open this safely if we use the green pass at the entrance, but incentivize, obviously, the younger individuals. So these are the first doses coming to Israel. For those of you who know, on the stairs, you see the Prime Minister and the Ministry of Health and all the people looking at this shipment, very exciting. We had a really elaborate supply chain and distribution channels. I'm not going to go over all of this, but as you can see on the right-hand side, we're actually able to decrease the size from roughly 1,000 doses to 10, 15, and 50 dose cartons. And that was critical for us when we were trying to get to remote places or home to bedridden individuals. We couldn't waste 1,000 doses tray. One of the things that I think made a difference was all the leaders of the medical community were first in line to be vaccinated. This is obviously the first recipient, the Prime Minister. After him, the Minister of Health and the CEO, the Director of the Ministry of Health were vaccinated. And the day after, all of us from the Ministry of Health, the first day, all of us got vaccinated. The CEO of the HMOs were vaccinated on the first day. The CEOs of most of the hospitals, if not all of them, were vaccinated on the first day. And so there was a big statement of, this is safe, we're going first in line. These are some pictures of how the HMOs actually spread out. They were not vaccinating in their usual clinics. They actually came out, reached out, created those vaccines centers and vaccinated massively, much more than they could in their own clinics. The outreach was in several ways. One of them was the outreach in the media. We realized that in order to influence the public, we need to get to them in many ways, in different social media. We need to make sure that people who influence opinion leaders are there in videos showing their arm and how they are going to be vaccinated. So there was a lot of media outreach, and you see this on the left-hand side. And I put in red because it was important, but it kind of balanced the picture that we also saw or showed documentaries in COVID units. So on one hand, you have this vaccine that is safe. Everyone wants to be immunized, has different incentives. And on the other hand, if you're not vaccinating, then the risk is the COVID units, and you see people who are intubated and in really difficult conditions, and you see both. So it's very clear, and none of them is manipulation. You have this tool to decrease disease, and we know by by professional literature that this is effective. And on the other hand, you show the disease itself and its toll. And again, at that point in time, we had a surge in disease rates. So we had, the hospitals were filled with patients. The outreach was also, that's on the right-hand side, needed to be geographically. We needed to get to nursing homes. We needed to get to bedridden individuals who are at the high-risk population. We needed to get to remote locations. The Bedouin population in the Negev are not going to get to your vaccination center in Tel Aviv. You need to get to them. You need to vaccinate them in their homes or in their tents. You need to get to them. So that was a lot of work that was done with local authorities to bring up those vaccination centers all across Israel, especially in the periphery. And we needed to do some outreach to special population and addressing their concerns. Why are Jewish religious groups are not vaccinating. And once we were asking those questions, we realized that there was some hesitance because of fertility issues, and we needed to address those concerns. And then the Ethiopian population, why are they not vaccinating as the rest? And we needed to address their concerns. So really figuring out who are less likely to be vaccinated and trying to figure out why, and actually bringing them the data with their own opinion leaders from their own community to explain what's the benefit of the vaccines and why we think it's safe and worthwhile. These are the immunization sites. We had approximately 400 of them. We were vaccinating 7 days a week, and it was run really tightly. So we had less than 2% no-show for the second dose. And we got to over at 1 day or 1 week, we had more than 200,000 doses per day. And I have to say that was the thing that was most surprising to me. When we thought about this, the HMO vaccinating in the middle of COVID-19 pandemic, when they have hundreds of patients that they're caring for in the community, they had hundreds and thousands of patients in the hospitals. None of us thought that they will be able to also vaccinate 200,000 doses per day. So that was amazing. And this is the result. You see Israel at the top, really going up very quickly in the vaccine campaign. And as I said, that was the target to begin with. You see the breakdown by age. You see that in the age group of 60 to 69, and we have 89% that are actually, so that's the 50 and above. But in the elderly group, 60 and above, we have more than 90% vaccination rate. And all along in Israel, we have about 85% that are from the eligible population that are vaccinated. And obviously recovered, we have more. So we were tracking the adverse event reports by category. You see here just a snapshot of that, but the green is the first dose and the orange is the second dose. So we were looking at systemic reactions and allergic reactions and neurologic reactions, and we were tracking them to see if there is no signal that we're missing. And we were reporting this, first of all, to ourselves to see what's happening with that in our committee, as I said, but also to the public. And the impact. So sometime in February, which was about 2 months from the beginning, we started to see a decline that was very prominent. It's not a small decline. It's not something that you're hesitant. I'm not sure if you can see what I'm showing to, probably not, because I can't. Oh, here, I hope you can see the markers. So when you have this decline, you're not sure if it's something really significant, but when it starts to drop, then you see it. And the same here. So this is the new severe and critical patients, the drop in them, and this is the active severe and critical patients. And we were looking to see that picture. We were looking to see the change in the pandemic, not on the confirmed cases. That's important, but our goal was to decrease severe morbidity and mortality, and we were looking at those graphs every day. But we also looked at the confirmed cases. So here you'll see several slides showing the infection rate per 100,000 based and compare it to, in different age groups, you'll see it in a minute, and compare it alongside with a graph that shows the percentage of people who are fully vaccinated or partially vaccinated. So in each of those slides, the more bright color is the partially vaccinated and the more intense color is the fully vaccinated. And as you see, the more of the population being vaccinated, the line that you see, which is actually the confirmed cases for that group per 100,000, at some point is decreasing. And you see it here on the right side for 85 plus, on the left side for 75 to 84. And the same Same picture is actually for 65, 74, 55, 64. You can just see the same effect. Once you get to some critical immunized population, you start to see the drop in the infection rate for that group. But what we also saw was this, which was the rate per 100,000 by week for the age group of 0 to 15. So I'm not going to say here that we got to herd immunity. I'm not sure we got there, but there is definitely community protection, indirect protection for the kids based on the vaccinations from the adults. This nationwide evidence of vaccine effectiveness was published in The Lancet. This was the first nationwide data in the world to see in real life, nationwide, the effectiveness is, as you can see here, there is a very high effectiveness for different outcomes. The only thing, and I have to say this very openly, the only thing that we are not sure about, and in this article we are explaining this, is the asymptomatic infections. As you've heard before, one of the incentives were if you're vaccinated, you don't need to be isolated when you come into contact with a confirmed case. In Israel, once you got to contact with a confirmed case, you go into isolation and you are required to do two testing, one at the entrance and one when you get out of isolation. If you choose to, you can go into 14 days without any test, but if you choose to shorten it to 10 days, you need to do two testing at the entrance to the isolation and at day 9. And so if the policy has changed for the vaccinated individuals and they don't need to go into isolation, they have less reasons to be tested for COVID-19. And so the difference between them, between the vaccinated and the non-vaccinated, is now created by the policy that they are testing differently. They have different reasons to be tested. But for symptomatic infection, for COVID-19 hospitalization, obviously critical, severe or critical and mortality from COVID-19, this is something that we can definitely say there is no difference between those two groups. Those are groups, all symptomatic patients were tested, and we know that the effectiveness is accurate. This was also was summarized by Anthony Fauci and in the White House COVID-19 press briefing. And we were actually very proud that the USA is looking at Israel and stating the information that we got from our vaccination campaign. So really, last slide before we take it into questions, the lessons learned for us from here is, I think, the first thing is that you need clear leadership message and actions. I think the director for the Ministry of Health was really leading this in a very pronounced way. That the message that he got out was very clear. The actions were clear. He was leading this campaign. He was talking to the HMOs twice a day, every day, seeing what's happening. And so that was really a leadership role that he took and made a difference. The fact that it was centrally managed and distributed was really helpful. If we were getting to the HMOs their own stocks and not being able to make sure that we're using the whole nationwide stock wisely, this could have looked differently. Teamwork. What works in day-to-day well will work in emergency. We don't need to create different systems to provide immunization. We need to trust our HMOs. They're doing their job on a day-to-day basis in a teamwork with physicians and nurses and other staff. We need to give them the opportunity to do the same work in emergency. The fact that we went and launched a broad, easily identified priority groups. We didn't mess with chronic diseases that needed this really convoluted algorithm to figure out. We said 60, then we dropped it to 50, then we dropped it to 40. It was very clear. And so it became very easy to follow. The fact that we had digitalized opportunities with the EMRs, both the information about the COVID-19 test results and the information about the immunization was crucial. We were managing public perception. We were fighting fake news. We were asking Facebook and Google to drop all fake news media. So there was a lot of activity around that to make sure that it's not an arena that we don't look into. We were actually fighting that arena as well. Explain and incentivize less compliant population. So we need to figure out why people are not vaccinated. Obviously, the really hardcore of anti-vaccines group, we're not going to change their minds, but they're not millions. So we need to figure out, or we needed to figure out for the people who didn't go to their vaccines, why, and try to explain to them why it's important in their age group or in their setting, and incentivize them to make sure that they see the value in that, even for the 30-year-old who are not afraid of corona, and being for the long haul. We knew that at the beginning there will be an uptake of the vaccines, but then trying to convince really everyone will take time, and you need to be there patient. You need to get to vaccine sites all around the country. We need to understand different populations. You need to really invest in it and for a long period of time. And this is what we actually did. So thank you for your time, and I'd be happy to answer any questions if I can. And I'll probably drop the share so I can see you.
Well, thank you. Kol hakavod. It's extremely impressive. So for those of you who don't know me, I'm Dr. Martin Zand. I work at the University of Rochester, and I'm the Senior Associate Dean for Clinical Research, and my laboratory studies immunology, including to COVID infection and vaccines. So I'm going to start with some of the questions from the chat, but first, the most important question. What a difficult time. How are you holding up?
That's an interesting question. I think the only person, probably not too many people are asking that, but Hila is one of the people who are always asking me, how are you doing? So it's hard. It's not easy. But I came into this job, I can't even say midway. I've been doing this for 10 months, but it's not from the beginning. At the beginning of the pandemic, I was working in the hospital. And so in the first wave, saw that side. So when I entered this job, I sort of knew what I was going into, not completely, but sort of. And I think what really keeps me going is knowing that we're doing something significant. We're saving lives. We're actually saving lives. And for that, the cost, the personal cost, the family toll is worth it, because it's really, really important.
Well, your family should be proud, and we hope that you stay rested, resilient, and safe. So I want to ask a couple of compare and contrast questions. The first one is about the Green Pass. You may know that New York State is, I believe, the only state that currently has a digital vaccine pass, like the Green Pass. Israel, as you noted, has recently discontinued the use of the Green Pass. What advice would you have for us, and what conditions made it possible to discontinue the use of the Green Pass?
So, as I said before, the purpose of the Green Pass was not to incentivize people to get vaccinated. If that was the case, we would have left the Green Pass for the 12 to 15-year-old vaccine campaign. That was not the purpose. The purpose was really to create conditions in which the economy can come back to life with, at the beginning, hundreds and then thousands of people in events. and still do it safely. So what we felt is that at the moment we were tracking, and we're still tracking disease rate in the country. We see all the country green. There is no reason to continue the green pass. The infection rate is really minimal. There is no explanation or justification for saying to people who have not been vaccinated and there is not much disease going around, you can't enter places. So because the reason from the beginning was to make sure that in high disease rate, we can still open economy safely. Once the disease rate is down, we remove the green pass.
Excellent. So this is a compare and contrast question, and I'm going to ask Dr. Mendoza to comment as well. So first, Dr. Alroy-Preis, can you comment on the current policies about wearing masks for children attending school in Israel? And then I'll ask Dr. Mendoza to briefly comment on the same for New York State.
Our policy was to make it simple. So at the beginning, we said when infection rate came down, we said we can drop the masks outside. And I know the CDC came out with the recommendations that if you have several people who are vaccinated together, they don't need to be with masks. We said we can enforce this. We don't know who was vaccinated and who was not vaccinated. It's not something that we can enforce. So what we decided is to go with the out versus the in and keep the masks in for everyone when we had still disease rate that was going up. Then the other part was, I have to say it in the bigger context, when you are dropping restrictions, it has a risk that you're taking. And so along the way, we were dropping or letting go of restrictions gradually, one by one. And so we decided that we will start with the restrictions that have the heavier cost on us. So once the disease rate went down, the first thing we did was to bring all the kids back to school, all ages together. That was risky, but we said that's the most vulnerable thing that we had from this COVID pandemic, that schools were closed, and that's a heavy toll. And then we said, okay, we can open economy more, and then we can enter places with a green pass with no restrictions at all. And the last thing is really is losing the green pass. And the last thing is the masks inside, which we're going, if all goes well, on the 15th of June, we're going to drop them. And we'll see how it goes. But one of the things that we are still contemplating is what to do with the schools. It is possible that at that point we'll say we'll still want to use this when you have context of highly unvaccinated individuals, which is obviously the schools, and if they're still indoors with less than 90% vaccinated individuals in the group, to keep the mask. But we're still contemplating on that.
Dr. Mendoza, do you want to comment about the New York State policies?
I think this is where I have to disclose that anything I say does not reflect the views of my employer. We should have done it here in New York as well as in the United States, very similarly to how Israel had. I think most of us in public health had that intention, but as things rolled out here in the United States, a lot of what happened was ultimately made as a decision of policy by politicians. And so a lot of how this progressed came out as very inconsistent communication, very inconsistent application of policy, and very inconsistent ways of enforcement. And so a lot of what Dr. Alroy-Preis mentioned is true here, and what had been done in Israel is what we wanted to have here. We should have prioritized schools and nursing homes first. And instead, schools were deprioritized, you could argue, toward the end. I mean, the only sector right now that's not allowed to go mask-free if you're vaccinated is schools. And schools are suffering a huge consequence. And obviously, there are kids in the schools who are not able to be vaccinated. But the reality is, even though we know that masks are more effective indoors, the prevalence in the community is so low that if we allow masks indoors, I have no concerns about that given the prevalence right now. And outdoor masking really never made much good sense. So, part of that is learned knowledge that we've acquired since then. But, last summer was a great test case in what happens when people gather outside. We didn't see really any cases of transmission, and very, very few morbidity and no mortality that I'm aware of, resulting from the protests and all of the gatherings and so forth from last summer. And then the other reflection I'll share is that the mask has come to symbolize more than covering your mouth and nose. It's become a political missile. And when that happens, it is very hard for all of us in healthcare to, say with a straight face, this is really just a mask, because everybody hears something very different. And so, there are many examples of things I wish we could have done differently in the United States or here in Monroe County. But I will say that those are probably the two that stand out to me most.
So that's a great segue into false information about vaccines. And so as somebody has asked, and one of the prevalent questions is in the United States is that, well, the vaccine certification was emergency rushed, it wasn't tested, it's not safe. Can you comment in Israel first, and then I'll ask Dr. Mendoza to comment. What was the vaccine certification process in Israel? Was it rushed or incomplete?
No, it wasn't. So what we do in Israel for all vaccines is that we wait for the FDA approval, or EMA, but we were waiting for the FDA. And we are going through a process in our regulatory division in the Ministry of Health. They're looking into the data with all the information from the company, doing their own analysis. The other step is after they are saying, yes, we agree that this is safe, which is a lot of it is based on FDA approval. I have to say, we're not going through this extensive regulatory process once there is FDA approval, but there is a shorter process in the Ministry of Health. Then we really insisted on making sure that we do batch testing. It's something routine that we do all the time. There was difficulty at the beginning. There were not a lot of labs that could do batch testing for the COVID-19 messenger RNA platform. And so we were looking all over. We found at the end in Europe, in the UK, a lab that could do this. And we were insisting on making sure that what we do is that we get the batch and a sample from the batch is being tested to make sure that what we think it's in there is in there. And only after we did the batch testing, as we usually do, then we actually cleared it for the vaccination campaign. And it was really very close call. So we got the test results on Friday, and the Prime Minister announced that he's going to be vaccinated on Saturday. And we were joking that there is a real chance that he will be vaccinated with something that we didn't test, but we're not going to give it to all the citizens. But if he's choosing to, that's fine. But we got it really a day before his vaccination. So we were doing the same thing that we do all the time.
Excellent. Dr. Mendoza just messaged me that he has to step away for another interview. So I'm going to ask the last question, near and dear to all of our hearts. Those of us who long to travel back to Eretz Yisrael and see all of our friends in Modain and across the country. What can you tell us about what it takes for those of us in the diaspora to return to Israel?
So the challenge that we have with traveling is two ways. The first one is that we saw all over during the whole pandemic, really false information, forged certificate of PCR testing, forged certificate of recovery from hospitals. It was pretty amazing what people were able to do. Serology testing, and you got test results for someone in lab in Israel when at the time he was not even in the country. So you realize that this cannot happen. And so we decided that because this is so crucial to us, then we need to authenticate the vaccination status. We can't just say, oh, they're bringing some kind of document, we're going to trust it. And we have decided to do serology testing for people when they enter the country. This will not be needed once we get to a point where we can validate or authenticate the certificate in an electronic way. So for us, we have a vaccination document that has a QR code, and every country that wants to scan this code and look at the data that the Ministry of Health is actually confirming that this is a vaccinated individual. If we had the same way of confirming, then we don't need serology at all. So, so at the moment, if you are traveling, then and you're vaccinated, then you need to do serology testing at the airport or after that, but only with positive test results, you can go out of isolation. And again, once we are able to authenticate with different countries their documentation, we won't be needing that as well. So that's one thing. The other thing is, how do we look into disease rate in different countries, and what's the risk coming from those countries? And so what we have done is, and still doing, is every week we're looking at all the data from all the countries. We're deciding which country for us is very high risk of disease. It's actually based on people coming into Israel from that country and being confirmed. So it's less based on all kinds of models, Our World in Data, all those websites that show the data from the world. We look into that, but that's not a criteria for a country to be entered as very high risk for disease rate. Those were considered very high risk. We are not allowing people to travel to them, and everyone who returns from them is required isolation, even if they're vaccinated or recovered. And then we have different travel warning to different countries. So the US is obviously not in the very high risk. We see the disease rate coming down with when the vaccine coverage is going up. And so we are starting to look at models of green countries. What are the countries that their vaccination coverage is so high and their infection rate is low enough that it's almost like Israel? And so traveling to those countries is not a risk. And once we get to those criteria, then I think everything will be simpler. Even people who are not vaccinated from those countries will be able to maybe go in without isolation, or kids will be able to travel with no isolation. So we're trying to find the model and manage those risks. To us, the biggest risk right now is the imported disease, and we're trying to make sure that this is not something that will increase the disease rate in Israel.
So if I land in Israel with my QR code Excelsior Pass, what would I expect in terms of isolation, testing? I get tested at the airport. Then what do I have to do, and for how long?
So before you board a plane to Israel, like I think in many countries, you need to do a PCR testing that is within the 72 hours before the flight. And that was actually one of the biggest things that I think changed how many confirmed cases were entering our country. So you're trying to find sick people even before they board the plane. Then once you land, everyone is required for a PCR testing, everyone, vaccinated, recovered, everyone. But if you're vaccinated, and if we can confirm these tests or the document that you showed, or people who are doing serology testing and are found to be serology positive, you don't need isolation. You just go out. So previously, when we had the Green Pass, we were also doing a lot of work in order to give Green Pass for people who came to travel because they still want to go to restaurants and to culture events. Now we don't have the Green Pass anymore, but isolation is not needed if you are recognized as immunized or recovered in Israel.
Okay, thank you. I think we are at time. I want to thank Dr. Mendoza for joining us. And this was tremendous. We have a lot to learn from Israel. And we hope that your efforts continue to bear fruit.
We hope so
you.
too.
So
I
thank
think
you. I
we're
wanted to just say,
only in the Ministry of Health, we're still very anxious to see that nothing goes up, and all the rest of the country feels that the corona is behind them, but we're still on the lookout.
for sure, for sure. Dr. Zand, thank you so much. Dr. Sharon and Alroy-Preis, this was such a fascinating presentation. Thank you for sharing your insights, the lessons that you've learned. You know, Israel certainly has been a leader in so many different fields, and certainly in this area, we have so much to learn from what Israel is doing. I also want to thank Dr. Chesson. Thank you so much for leading the discussion earlier with Maimonides Society members. Thank you to all of our distinguished, physicians who joined as part of the Maimonides Society, and thank you to all of our community members for being here for this important discussion. This was really, like I said, fascinating. We've got lots to learn. And once again, also thank you to Dr. Mendoza for being here, for weighing in and sharing some of the information from Monroe County and what's happening here. So thanks again. And we hope to see you at our next event as part of the Partnership Together Adult Education Series.
I promise Hila that every time that you invite me, I will come.
It's fabulous. It's such a privilege. Thank you. And yeah, this would not have happened without Hila Hadass, who's a member of our committee. So thank you once again.
תודה שרון, תודה מיכל.
Thank you, everybody.
ביי ביי. תודה, לילה טוב.
תודה רבה. תודה שרון על כל מה שאת עושה.
תודה.
תודה.
I'm adding Hila over here. I should have added you earlier.
She's fabulous person, really.
She's
Such
great.
a strong, and just to see her every other day on the TV, when all the interviewers, they punch her and they, and she is stubborn as a rock. And
Yeah.
she says, that's it, and we are not going to, to do any shortcuts or waivers. And there were days that I, just for use a Martin,
Sorry.
there were
There we go.
days that
Now we're all together.
I called her after interviews just, to give her some strength, because it was, I don't know how she stand it, it was, so.
She must have a very
Enjoyed-
supportive family as well.
Yeah, I enjoyed this presentation, to hear her all, that's nice. So
Yeah,
Yeah, no,
it
she
was
was
great.
fabulous.
Yeah,
lucky us that she could do it, and
Yeah.
This is not something that she normally does. I know. So it was just such a, we're very, very appreciative.
Yeah.
For her to take the time to do this
it
for
was
us.
great. She was
Absolutely.
wonderful.
And
Yeah.
Dr. Zand, you were fantastic as a Q&A
Yeah.
moderator. I
As
think I need to
always.
call you in for future events.
as always.
Yeah.
I do a lot of moderation, so happy to help out. This was spectacular.
That was really well.
Yeah.
Unfortunately,
very
a
interesting.
little bit of technical difficulties in the very beginning, but it worked out.
Yes.
תודה רבה. See you
Okay,
soon.
לילה טוב.
לילה
Let's
טוב.
Bye.
hope in
Hila.
Israel. Thank you,
Bye.
everybody.
Bye-bye.
We'll see you next tomorrow. Yeah,
I think we have a
tomorrow. I'll
meeting
see you tomorrow, Michal.
Yes.
Yeah.
Yeah.
תודה,
Bye.
אביבה. להתראות.
Bye.
Thank you.